Good afternoon, good evening, and good morning to all participants joining us from different parts of the world. Welcome to the 18th IUSG Grand Rounds, dedicated to exploring one of the most intriguing and clinically relevant topics in ocular inflammation, drug-induced uveitis. This session will begin with a thematic lecture by Dr. Megan Birkenstock, uveitis specialist at the Johns Hopkins Wilmer Eye Institute, who will discuss how to detect and manage drug-induced uveitis, an area that continues to challenge even experienced clinicians due to its diverse presentations and overlapping features with infectious and autoimmune entities. Following the lecture, we will move on to 3 illustrative case presentations. Case 1, uveitis associated with biologic therapy, specifically anti-TNF alpha. Case 2, uveitis induced by cancer therapy. Case 3, uveitis following antimicrobial therapy. Each case will be followed by discussion with our distinguished panel of experts, Dr. James Rosenbaum, Dr. James P. Dunn, and Dr. Lucia Sobrin, who will share their perspectives and practical insights on diagnosis and management. We anticipate a highly educational and interactive session highlighting how pharmacologic agents can trigger or modulate ocular inflammation and how these mechanisms influence our therapeutic decisions. Megan?
Thank you for inviting me to give this talk. It's something that I am passionate about and where a lot of my research comes from. So it's exciting to be able to share it. I hope my screen works. Can you see it?
Yes,
Yes.
Megan, it's working. Can you go to slideshow? Perfect.
Excellent. Okay. Well, these are my disclosures, some of which are relevant, but I will only use generic names, and I am not going to have any specific product disclosures during this discussion. So we're just going to talk a little bit about the timeline in which these drugs entered the market, and then 3 different classes that you will encounter in your clinical practice, and then finally a few closing thoughts. The era of immune therapy really started in 1997, and we know and love Rituxan in the uveitis community for treatment of vasculitic scleritis and retinal vasculitides. However, it was first approved to treat B-cell non-Hodgkin's lymphoma in 1997. Later in 2001, Gleevec was released as the first small molecule kinase inhibitor and actually won the Nobel Prize. Some of the medications we're going to be talking about today were released in the United States in 2011, the first of which was ipilimumab, which was the first of the checkpoint inhibitors. And then in 2014, the MEK-BRAF inhibitors were FDA approved for treatment of metastatic non-operable melanoma, but have since had expanding indications to treat solid organ tumors. So let's move on to the checkpoint inhibitors. So they're monoclonal antibodies, and I'm going to show you and break it down in a cartoon on the next slide, but there's 3 sites where they work. First, they upregulate antigen presentation to dendritic cells, which then promote T cell responses both in the lymph node and in the tumor bed. So if you look at the bottom left of the screen, and I'm not sure if you can see my mouse, but you'll see the gray cells are the tumor burden, and constantly tumor antigen in the shape of these golden stars are released into the peripheral circulation. And that's where they encounter circulating dendritic cells, which uptake the antigen, process it, and place it on MHC molecules. And then the dendritic cell hones to the closest lymph node where antigen is then presented to naive T cells. And if you remember from medical school, there's 2 signals that are needed to activate a T cell. The first of which is the T cell receptor interacting with the MHC molecule. And the second we'll talk about because that's one of the ways that the checkpoint inhibitors interact and activate the T cells. So if you have a fully activated CD8 cytotoxic T cell, after the 2 signals have been received, it will leave the lymph node and then hone down into the tumor bed to cause decreased tumor burden and tumor lysis. But there's another problem that can happen in this cascade. On the tumor surface, there's also expression of certain proteins that are upregulated called PDL1, as you can see in the lower right-hand portion. If a T cell is allowed to bind that, even though it's activated, it will lead to the T cell being deactivated and then leading to immunosuppression. So if you look at the top photograph, the deactivated T cell will have the T cell receptor bind the MHC molecule on the antigen presenting cell or the cancer cell. And then you'll see off to the left, there's an orange and green schematic, and that's the second signal. So if we move down to the bottom left, the anti-CTLA-4 antibody, we have an activated T cell, or we hope, in the lymph node. So this is more of an upstream activated medication. Again, the T cell receptor, the MHC molecule, and then you'll see two other molecules on the activated T cell surface. First of which is CD28, and that's the second signal. CD28 has to bind CD80 and 86 on the antigen presenting cell. If that doesn't happen, you don't get an activated T cell, you get a T regulatory cell, and then the tumor is allowed to proliferate. The problem is not only can CD28 bind CD80 and 86, you can also have CTLA4 bind. And if that happens, it leads to Treg formation. And so by blocking the CTLA4 protein on the T cell surface, it allows for continued CD28 activation and T cell activation. Same thing in the tumor bed, as I mentioned before. You just want the activated T cell receptor to bind onto the cancer cell MHC molecule. But there are other competitively inhibiting substrates. So you have PD-1 on the T cell surface and PD-L1 on the cancer surface. And if they are allowed to bind, it leads to deactivation of the T cell, immunosuppression, and increasing tumor burden. And so if you block either PD-1 or PD-L1, you can have continued activation of your T cells and a decreased tumor burden. This is a list of all the FDA approved checkpoint inhibitors. The new kids are on the block or on the right-hand side. So they're LAG-3 inhibitors. They have an activation of lymphocyte activating gene, which again increases the likelihood you're going to get a CD8 positive response as opposed to a Treg response. Most of the clinical trials, when these were being developed, excluded patients with autoinflammatory disease, thinking, well, everybody's going to get an increased risk of autoimmune disease with the use of them. But unfortunately, it seems like almost everyone who takes these medications have some kind of immune-related adverse event, the most common of which includes lymphocytopenia and increased LFTs, liver function tests. Systemic side effects are a side effect of the overactive immune response driven by the cytotoxic T cells, and it starts weeks to months after starting therapy and can even occur after stopping the medication. They're more frequent and severe with CTLA4 inhibitors because of the more upstream action in the lymph node, and higher with combination therapy when you pair a CTLA4 inhibitor with a PD-1 or a PD-L1 inhibitor. Most are low grade and you can continue therapy. Sometimes you need to use topical, inhaled, oral, or even rarely intravenous corticosteroids, especially in the case of checkpoint inhibitor-induced arthritis. Other immunosuppressive medications may be needed. Rarely are they for the eye. If severe, you may temporarily or permanently discontinue one of the checkpoint inhibitors, but again, that is usually your last resort. We're lucky in the eye because to promote visual function, we have several mechanisms to prevent inflammation, which is why uveitis is so rare. We lack efferent lymphatics, there's the blood-retinal barrier, and finally, we have upregulation of transforming growth factor beta, and interestingly, and we'll come back to this later, RPE cells express PDL1. And so normally that is present to downregulate any aberrant T cell responses that may be occurring in the uvea. But remember, if we block PD-L1, we allow activated T cells to enter that specific part of the body, including the uvea. Ocular adverse events, because of all these reasons, occur in less than 1% of patients, in some studies up to 2 to 3%. So we're going to talk about each part of the eye and what can be affected. So on the ocular surface, the most common adverse event by far and away is dry eyes. And that occurs in about 40% of patients, also episcleritis, blepharitis, and interestingly, an inflammatory keratitis, which has been reported to cause corneal graft ulceration and rejection, have been reported. So here's some examples of some patients on checkpoint inhibitors. So in the upper left, you can see someone who has developed fluorescein staining for an epithelial defect due to severe dry eyes. And then later on, as you can see on the right-hand side, there's resolution with corneal scarring. Always remember that you can have infections present in these patients, and that drug-induced side effects of the medication are always your rule-out diagnosis, because as you can see at the bottom left-hand side, herpetic keratitis can also happen in this population, so keep your differential broad. Same thing at the bottom right, superficial punctate keratitis is one of the most common findings, again associated with dry eye, which is treated with increased artificial tears and sometimes additions of cyclosporin, serum tears, or punctal plugs. Blepharitis should always be managed to decrease the risk of dry eyes as seen on the top photo. And at the bottom, unfortunately, you can still develop symblepharon. And what I'm trying to show you here on the right-hand side is that at the bottom lid, there actually is a fornix developed as opposed to the left-hand side where it's absolutely absent. And so you really need to take care of the ocular surface in these patients to maximize the outcomes. Orbital adverse events involving the eye, the most common of which is myasthenia gravis. And I counsel you to look out for this because in the clinical trials, death from respiratory failure was reported. And it's no different than myasthenia gravis that would occur in a patient not on one of these medications and is managed with corticosteroids, IVIG, and referral to neurology for either plasmapheresis or pyridostigmine or mestinon. Orbital myopathy or inflammatory orbitopathy can also happen, in addition to dacryoadenitis and a thyroid-like orbitopathy. You can also have a cranial nerve palsy. However, I counsel you that if you see this in a patient with an underlying malignancy, again, this is a rule-out diagnosis, low threshold to order neuroimaging in order to make sure that you're not missing a metastasis or another organic cause for the new onset cranial nerve palsy. Here are some patients that I've seen with these, sorry, I have a cold, with these conditions. You can see the lid lag on the upper left in the patient's right eye and the fatigability on up gaze. And then on the right hand upper side, you can see the lateral flare, lid retraction, and chemosis of a thyroid leg disease. And then on the bottom, when you lift up the lid in a patient with dacryoadenitis, sometimes you have lacrimal gland prolapse. PMR or polymyalgia rheumatica and giant cell arteritis should also be in your differential. The average time to onset is within the first 5 cycles. They will have the characteristic elevated ESR and CRP. Sometimes they present with a retinal vasculitis leading to an occlusion or a BRAO, and sometimes they come in with edematous pallorus nerves. Refer for temporal artery biopsy, and resolution with oral corticosteroids on taper has been reported. Uveitis, besides dry eye, is the most common adverse event, and the curiosity is that it can occur in any anatomic location, so anterior, intermediate, posterior, or panuveitis. The most common presentations are what we usually see in our clinic: eye pain, light sensitivity, floaters, and blurred vision. The median time of onset is within 6 to 12 weeks, and again, anytime you see a patient with new onset uveitis, you have to do the workup. You have to rule out infections like syphilis with a treponemal and a non-treponemal test. You have to order B27. In my part of the world, I also order Lyme, and then I also do a chest radiograph to screen for sarcoidosis. As long as the patient has both eyes, the inflammation's always bilateral, with a smattering of anterior chamber cells and variable amounts of cystoid macular edema. When posterior uveitis is seen on examination, it has a wide manifestation, ranging from placoid retinal lesions like you would see in syphilis to a multifocal choroiditis or even a birdshot-like choroiditis. Cases of VKH-like panuveitis also give you the sunset glow with extraocular manifestations like hearing loss, meningismus, and vitiligo. We try to manage topically and periocular or intravitreal corticosteroids in these cases, because once the systemic corticosteroids are started, the immunotherapy is held until you get down to 10 milligrams of prednisone or less. Because if prednisone decreases your immune response and you're trying to give a drug against the cancer cells that upregulates the the immune response, there has to be a delicate balance, and that starts at 10 milligrams of prednisone. Here are some patients in the upper left-hand corner. It could be a granulomatous or a fine keratoc precipitate that's seen on the upper left, or I'm sorry, the upper right. You'll see the striae coming off of the optic nerve in a patient with a VKH-like response to the checkpoint inhibitor, which you can see at the bottom compared to the normal anatomic appearance of the fovea leads to pockets of subretinal fluid. Pathogenesis is speculative, but again, I mentioned before that you have activated T cells primed against antigens with epitope similarity to uveal proteins, especially in cases of melanoma where you're lysing cells that produce melanin and are pigmented. It may facilitate inflammation of the T cells in the uveal tract, specifically in the RPE, because we do know that melanin-associated proteins have been shown to induce experimental autoimmune uveitis. This is one of my patients. I think this is the worst case of a uveitis that I saw with the checkpoint inhibitors. The normal color of his skin is actually the darker brown color, so he had diffuse vitiligo, and that same pattern on his skin mirrored what happened in the back of the eye with diffuse pigmental loss and decrease in vision. I would be remiss if I didn't tell you to look for optic neuritis. The curiosity with this is it doesn't present with the usual pain on eye movements that one would expect or see with regular optic neuritis associated, for example, with multiple sclerosis. But the treatments are exactly the same. Get an MRI with the orbits, start corticosteroids, and then co-manage with neurology. I'm going to switch in the interest of time over to the MEK and BRAF inhibitors. And I like this schematic because, as you can see at the top, it's a chain or a pathway of kinases. So they use phosphorylation to activate the next step in the chain. And because there's multiple steps, there's multiple places where you can intervene. Some tumors overexpress FGFR receptors, and this is more of one of the downstream regulators of that pathway. So the most common places to stop proliferation include blocking at the BRAF, MEK, and ERK positions in this cascade. Ultimately, if you do that, you shut off transcription in the nucleus, which decreases cell growth and also decreases cell motility, leading to decreased metastases. So again, their growth signal transduction protein kinases. Mutations in the cancer cell lead to continued activation. The downstream effects include tumor proliferation and motility. These are the FDA-approved medications, and while they have a high response rate, the response is short-lived with a median time to progression of about 5 to 9 months. If you add a MEK inhibitor to a BRAF inhibitor to decrease the activation of the pathway at several positions, you extend the median response, but not much, only to about 6 to 10 months. BRAF inhibitors have uveitis as the most common side effect, and it truly is a drug-induced uveitis in clinical trials, because if you re-challenge the patient, they will develop the uveitis again. Anterior, intermediate, and panuveitis have been reported. Again, it is controllable with topical, regional, and systemic corticosteroids. And interestingly, it is not only bilateral, but the mean time of onset is right around the time where the drug starts to become inactive, around the 6-month time point. MEK inhibitors cause a completely different pathophysiologic response. And so multifocal central serous like chorioretinopathy has been reported and is called MECAR. It's bilateral and it's usually within a few days after the initiation of the drug. The thickness of the retinal detachment on OCT, and they are multifocal, appear in a dose-dependent manner, which resolve over time, normally without dose change or discontinuation. But also know that you should be conducting DFEs to look for dilated fundus exams to look for retinal occlusions as well. Here's a picture of a patient with MECAR. Again, multifocal areas, and when you look on cross-section, there are subretinal fluid pockets in each one of the areas, which do resolve over time, even though the vision, especially if it's subfoveal, as in this photo, is reduced on presentation. So again, just like a lot of the drug-induced uveitis, it's not well understood, but we do know that the MEK pathway inhibition can lead to a variety of intracellular changes, which includes inflammation and actin cytoskeletal dynamics, which alters the intra and extracellular water transport, disrupting the outer blood-retinal barrier and leading to oxidative changes and loosening of the tight junctions. And it's the thought that this dysregulation of the tight junctions in the non-pigmented ciliary body epithelium can contribute to the inflammatory reaction leading to the anterior uveitis. And my final class that I'm going to talk about today are the antibody drug conjugates, which are the newest agents. Antibody drug conjugates are monoclonal antibodies, so similar to the checkpoint inhibitors. However, they are designed differently. They deliver chemotherapeutic drugs directly to cancer cells. So as you can see here on the bottom right, you have a monoclonal antibody that is directed against an overly expressed surface protein on a cancer cell surface. And the cytotoxic payload, which is the traditional chemotherapeutic drug, is the red star, and it's linked to the monoclonal antibody via the red dotted line, which is called a linker. And the linker can be cleavable or non-cleavable. So when the monoclonal antibody binds to the surface receptor in which it is targeting, it will be taken into the cell, processed in the lysosomes, thereby leaving the cytotoxic payload in the cytoplasm, which then can migrate to the nucleus, because a lot of the cytotoxic payloads either work by microtubule disrupting microtubule formation, so preventing mitoses, DNA damaging, or even modifying RNA as it moves through the cytoplasm. So collectively, irrespective of the type of chemotherapeutic drug, the goal is to decrease cell proliferation. And there can be variable amounts of the cytotoxic payload, ranging from 2 all the way up to 8 molecules attached to each of the monoclonal antibodies. The most common ones that we encounter in clinical practice include tisotumab, which is a second or third line agent for cervical cancer. It's directed against tissue factor. And we'll talk more about that later, because unfortunately, tissue factor is also expressed on the ocular surface. Mirvetuximab, which is second or third line agent for ovarian cancer. And finally, belantamab was FDA approved for multiple myeloma, but failed to meet its clinical endpoints in a phase 3 clinical trial and was pulled from the market in 2021 in the United States. However, it's still being used elsewhere, including in Europe, and in combination with traditional chemotherapeutic agents. And so I would like to still mention it, because even if you're in the United States, some patients remain on it for compassionate use protocols, but also it is still being used in Australia, in the UK, and also in Europe. And that targets B cell maturation antigen. So tisotumab is a fully humanized antibody drug conjugate. It has a microtubule disrupting agent as its cytotoxic payload. But again, the ocular surface is unfortunately a bystander and is targeted because tissue factor is expressed on the surface. Most adverse events are conjunctival inflammation, and it requires a slit lamp exam every single cycle for the first 9 cycles. It is one of the medications that has a black box warning from the FDA, meaning that there are eye mitigation protocols, which we'll talk about a little bit later. When we talk to oncologists, because inevitably we do with these medications, we have to go back and we have to think about using the same terminology. Unfortunately, there is something we have to learn, but fortunately we have a scale. And so the National Cancer Institute in the United States has come up with a terminology called the common criteria for adverse events. And what they do is describe in lower to higher the adverse event grading scheme. So if you're grade 1, it's less severe. If you're grade 4, it's Vision threatening, and grade 5, which we don't, thank goodness, have to deal with in the ocular world, is death. But I gave you a few samples here. There are over 20 different classifications for ocular disorders, ranging from conjunctivitis to retinal disorders to optic nerve disorders. Here I included conjunctivitis, dry eye, and keratitis. We're going to focus on keratitis because that is by far and away the most common side effect with the antibody drug conjugates as a class. So grade 1 would be an asymptomatic patient where we just give them artificial tears and watch. Grade 2, they are starting to become symptomatic, and their best corrected visual acuity is 3 lines decrease from their known baseline or their 20/40. And that's when we start thinking, okay, how do we prevent from going to grade 3? And that's where the mitigation protocols come in. Grade 3, the patients are usually symptomatic, their vision is getting worse, and they can also have a corneal ulcer. If a corneal ulcer develops on any of the antibody drug conjugates, it's a hard stop. You have to stop the medication. And the same thing with symblepharon in cases of conjunctivitis. So tisotumab, over half of patients developed ocular adverse events, the most common of which were conjunctivitis, dry eye, or keratitis, with a median time of onset between the first and second infusions, with a median time of resolution to about a month. So if there are patients who are grade 2, we normally hold the medication for a week, let the ocular surface reconstitute, and then reinfuse, knowing that the median time to resolution will happen shortly. The curious thing with tisotumab is conjunctival, these white plaques on the conjunctiva, which represent keratinization. So if you did a biopsy of these, you would actually see a stratum corneum and parts of the conjunctiva that we normally wouldn't see as a mucous membrane. And you can also, as I showed you before, end up with symblepharon, which unfortunately means stop of the medication. The mitigation protocols that I talked to you about, if we know that the medication is going to get to the eye, well, how do we stop it from getting there? Well, we do our baseline exams. We ask the oncology team to always do an ophthalmic review of systems. And right before the infusion, they use eye drops. So this is the one time I think we're all okay with Visine to vasoconstrict the ocular surface. Bromonidine has also been used. And then they also apply cold packs to the eye. So the cumulative effect would be to vasoconstrict the vessels to decrease the amount of the drug that enters the ocular circulation. So eyelid disorders, we all know how to deal with blepharitis with lid hygiene and scrubs. Again, if you have symblepharon, it's a hard stop. I try never to stop these drugs, knowing that the patients have metastatic disease. They have gone through the usual chemotherapeutic routes, and this might be their absolute last chance for survival. And so, unfortunately, your hands are tied if you end up with a grade 3 or rarely grade 4 event. Keratitis and conjunctivitis can be managed with topical corticosteroids, which the patients are directed to take after the infusions anyway, and in the case of ulceration, broad-spectrum antibiotics after culturing. Sometimes patch grafts, amniotic membranes, or even partial corneal transplants have been required. Mirvetuximab is another antibody drug conjugate. This one is targeting folate receptor alpha with an ocular exam needed every other cycle. The ocular toxicity is mostly in the cornea as opposed to the conjunctiva. And what happens are pseudomicrocysts, which are uptaken molecules of the antibody drug conjugate, lead eventually to cell death, but cause necrosis within the cell. And it's thought that the pseudomicrocysts are the signs of early cell death as the cell migrates peripherally from the limbus where the stem cells live all the way to the center of the cornea. And once in the center of the cornea, that's when you have the change in blurred vision that the patients will report. Most of these are grade 1 or 2, and as you can see in the photograph, it starts in the periphery and you'll see it come up and into the center of the vision as a wave, as the corneal cells slowly turn over in a 2-week fashion. Most common events are again blurred vision when the cysts are central, keratopathy, and there was no retinal toxicity because interestingly, folate receptor alpha is expressed in RPE cells. Though in clinical trials, there have been reports of anterior uveitis, especially in the phase 3 mirror cell trial, as will be presented at the AAO meeting by myself in a poster. Mirvetuximab mitigation protocols, again, you have to see the patient weekly until the symptoms resolve. And if they're grade 2, you hold the medication until you get back to grade 1. Corticosteroid drops have to be administered in the prescribed way that I have at the bottom after treatment. You have to tell the patient to avoid contact lenses because you want to decrease the risk of ulcer formation and also just having more foreign bodies in the area that you know will have potential for epithelial disruption. Also, sunglasses and use of blepharitis treatments. So I'm always curious. It's nice in clinical trials when you know what happens to the several hundred patients, if that, who are in the clinical trial, but what happens when you get to the real world? So how much uveitis or how much corneal toxicities do we see with these drugs? And so using a very large database called Trinetics, I looked at this particular clinical question. And over the time to follow up, you see that the amount of the either corneal ulcers or uveitis was not statistically significantly rising. Same thing with antibody drug conjugates. On the right-hand side, you can see that the most common side effects are dry and keratitis, but thank goodness corneal ulcer and uveitis are exceedingly rare with these medications. So you have to do your baseline eye exam, no contact lenses, use the corticosteroid drops as they should be used per the FDA guidance on the black box warnings. Vasoconstrictor eye drops and cold packs will be administered by the oncology team. Lubricating eye drops and prophylactically throughout treatment will help decrease the dry eyes and surface irritation. But if you have some blepharon or ulcerative keratitis, you have to stop treatment. Always refer to the latest prescribing information, and the oncology team should always monitor patients for ocular signs and symptoms because a lot of these adverse events are detectable before they become severe, allowing for early referral and management. Close communication between oncology and eye providers are needed. Most ophthalmologists aren't familiar with the grading system of the common terminology of cancer, of adverse events from oncology trials, but that's why we have these discussions today where we learn the grading scheme so we can translate what we see at the slit lamp into meaningful information that tells the oncologist, should I infuse or should I not infuse the medication? And you have to be vocal about whether or not you feel like the eye is ready to potentially have more adverse events. So are they grade 2? Should we hold it? Try to avoid the stop of the immunotherapies. Again, these are life-saving medications. We try our best to deal with the ocular side effects in order to keep the patient alive. And just know that oncologists are starting to prescribe the corticosteroid eye drops for the patients for these protocols for mitigation. So not only do they, but we also have to remind them to come back to see us to check the eye pressures to make sure that we don't have preventable morbidity with cataracts and glaucoma. So final thoughts, immunotherapy and targeted therapies, absolutely. We can continue the medication as long as we coordinate our care with oncology. Just know that ocular adverse events don't occur in a vacuum, and there may be other systemic manifestations and adverse events that will dictate the course of treatment. Because sometimes as an ophthalmologist, we get a little queasy making decisions about systemic medications, especially oncology medications. But again, this is a collaboration. But just know that we should be vigilant for life-threatening complications as physicians first and ophthalmologists second, including myasthenia gravis, giant cell arteritis, and metastases masquerading as uveitis. So if you have an intermediate uveitis in a cancer patient that isn't responding to corticosteroids, where the cells are larger and usually tan color, those are red flags in which to have a low threshold to refer the patient for a parsplantar vitrectomy. And always remember that the infection risk is always increased in these patients. With more experience, the list of the adverse events will only increase, and you should always think about them when you see a patient with new onset visual symptoms who also has cancer. With increased use, we're going to have more clinical indications, more cancers that these medications are treating. So you have to understand the adverse events that come with these medications. And just know either the side effects of uveitis would be rare in the antibody drug conjugates, but then unfortunately occur in 20, sometimes 25 to 40%, depending on the study, in a BRAF inhibitor. Adverse events could be blinding, so we need to see the patient. You might already see 60 patients in a day. Make them your 61st. Leave your door open if they have new signs and symptoms. And there are working groups that are trying to change the CTCAE to make it more specific. Is it keratopathy? Is it keratitis? To unify those diagnoses to be able to, that we can have the diagnosis that we need to relay to the oncologist. So algorithms for management of adverse events have already been put out, and I would like to include the National Comprehensive Cancer Network guidelines. These were developed for community oncologists, but it also gives you a springboard if you're not really sure what to do with an ocular complication of options for you and things to rule out. Furthermore, I direct you to read this really informative paper by Dr. Sobrin and colleagues, and I was so pleased to be part of it, where we talk about what are the definitions for ophthalmic immune-related adverse events. We all have to get on the same page that none of these adverse events are going away, and there's only more drugs in the pipeline. So we have to standardize our nomenclature to be able to have the discussion and treat our patients the best that we can. Thank you.
Very interesting and important presentation, Megan. We'll leave the questions for the discussion at the end. However, attendees may start typing their questions in the Q&A. Now, Dr. Eugenia Ramos Davila from the Wilmer Eye Institute will continue presenting the first case, which will be discussed by Dr. Rosenbaum. Eugenia?
Hello, good morning. Is everyone able to see my screen properly?
Yes,
Irina.
perfect.
Perfect. All right. Well, thank you very much for the invitation. I'm going to present a brief clinical case before Dr. Rosenbaum's presentation regarding biologic-induced uveitis. I have no conflict of interest to disclose, and this is the case of a 50-year-old female presenting to our clinic with floaters and blurry vision in both eyes, which started 7 months ago. She had no prior relevant family or personal history, and regarding her eyes, she had been treated with difluprednate in both eyes on a weekly taper without any improvement in her symptoms. She was now currently using it twice a day in both eyes. During the review of systems, she referred to have fatigue and lower extremity paresthesia. Upon examination of note, her best corrected visual acuity was 20/40 in both eyes, and the only other relevant findings were the presence of 2+ cells and snowballs in the vitreous, as well as plenty vitreous condensations in both eyes. Fundoscopic examination revealed the before said vitreous opacities and condensations, a well-perfused optic disc, and the only other relevant findings would be the presence of these chorioretinal non-pigmented scars, circular and seemingly chronic in nature, observed in the temporal inferior periphery. The FA of the right eye did demonstrate some small vessel involvement and leakage, optic disc staining, as well as a blocking defect associated with the previously mentioned opacities, and a window defect associated with the scars or lesions. The ICG did not demonstrate any relevant findings in the right eye, whereas the left eye on fundoscopy, we observe as well the vitreous opacities and condensations, as well as almost symmetrical choroidal lesions in the temporal and inferior far periphery, just like in the right eye. The FA also demonstrates some small vessel involvement, but in a lesser extent than with the right eye, and the ICG did not demonstrate any relevant findings as well. Macular OCT revealed a diffuse macular edema in both eyes without any intraretinal or subretinal fluid. At this moment, we have a bilateral intermediate uveitis presenting for the first time in a 50-year-old female. Differential diagnoses include mainly infectious etiologies. In the US, we test for Lyme and syphilis. It could also be due to inflammatory conditions such as sarcoidosis, for which we order a chest X-ray, and while less likely and lower in the differential diagnosis, multiple sclerosis. Since this patient did have some neurological symptoms, we decided to order a MRI of brain and orbits to rule out this condition, although it would be a late presentation of multiple sclerosis, which is only seen in about 5 to 15% of patients with this disease. This could also be due to a primary intraocular lymphoma or undifferentiated intermediate uveitis. Laboratory workup was negative for the first 3 differential diagnoses. We decided to continue the difluprednate weekly taper until discontinuation, and we started the patient on prednisone 60 milligrams a day. A month later, she came back using 20 milligrams a day of prednisone. She had noticed improvement in her vision and symptoms. Her best corrected visual acuity in the right eye was 20/25. We still see some vitreous opacities to a lesser extent, no new choroidal or chorioretinal lesions. The FA continued to demonstrate small vessel involvement to a lesser extent than the previous imaging. Left eye also presented an improvement in the vitreous opacities. We also noticed this inferior nasal lesions, circular and hypopigmented. We were unsure if these were present in the prior visits since the eyelashes were getting in the way, but it seemed like they were already there during the first presentation, and there were no other choroidal or chororetinal lesions. The FA demonstrated some small vessel leakage in the left eye, but then again showed improvement compared to the prior consultation. Macular OCT was stable with diffuse macular edema in both eyes. And at this moment, we included adalimumab 40 milligrams every other week as we continue to taper oral prednisone until discontinuation. 4 months later, after initiating adalimumab, the patient presented with an increase in her symptoms and discomfort. The best corrected visual acuity was 20/40 both eyes, and now at this moment, she presented a florid anterior uveitis in both eyes with keratic precipitates in the right eye and 2+ cells, whereas 1+ cells was observed in the left eye. The cells and inflammation in the vitreous worsened with a 3+ cells and 2+ cell in the right and left eye, respectively. We also see it on the fundoscopy. We see an extensive increasing amount of vitreous opacities in the right eye, as well as the small vessel leakage. The left eye also presented vitreous condensations and opacities in an increased amount, and a small vessel leakage in an increased amount. Macular OCT in the left eye now presented with intraretinal fluid, as well as the already seen diffused macular edema. So in this case, inflammation paradoxically worsened after 4 months of using adalimumab, and also the patient presented for the first time a new onset acute anterior uveitis. We decided to stop adalimumab and start a topical steroid to treat the anterior uveitis, as well as we scheduled the patient for a vitreous biopsy to rule out intraocular lymphoma. The biopsy came back and was negative for a monoclonal B-cell population. However, pathology did mention that these findings were non-specific but could be associated with autoimmune uveitis. We started the patient mycophenolate 100 milligrams twice a day. And at the 4th month follow-up, she had a noticeable improvement in her symptoms and vision. She was already using a full dose of mycophenolate. The FA demonstrated a lesser involvement of the small vessels and improved in the leakage pattern in both eyes. And the intraretinal fluid previously observed in the left eye had disappeared. As a conclusion, we deemed this clinical picture to be a drug-induced uveitis associated with adalimumab. Of course, it's perfectly reasonable to argue that this could be a failure in treatment due to adalimumab. However, the patient did have a chronic history of intermediate uveitis that, although was not responsive to prior treatment, it had not worsened. And at the same time, she presented new onset acute anterior uveitis. More importantly, the clinical picture improved and went into remission after we discontinued the TNF alpha inhibitor. This is obviously an uncommon adverse effect associated with these drugs. The best or the most reasonable theory about this pathogenesis is a cytokine disequilibrium, meaning that while TNF alpha in this case is inhibited, there's an imbalance or a disproportionate amount of other inflammatory cytokines, such as interferon, for example, that can lead to inflammation through a different pathway. The higher risk has been associated with the etanercept, a fusion protein that's documented to have a 3-fold higher risk of drug-induced uveitis compared to adalimumab, and almost a 2-fold increase compared with infliximab. Anterior uveitis is by far the most commonly reported presentation. However, there have been reports of intermediate posterior uveitis as well as even scleritis. Times to onset widely varies, but can be from 2 to 24 months after treatment initiation. And I won't give any more thorough analysis as we prepare for Dr. Rosenbaum's presentation, but this is the clinical case. Thank you very much.
Thank you so much, Eugenia. Dr. James Rosenbaum will discuss this interesting case. I think Dr. Rosenbaum let his presentation recorded.
Yes, you should have a recorded presentation. Are we able to upload that and share it? Do we have Dr. Rosenbaum's PowerPoint that we could share?
I want to thank Megan Bergenstock for the invitation to give this lecture. I'm going to cover broadly how do you assess whether epidemiologic factors are causally related to a disease. So 60 years ago, Sir Bradford Hill, who was a British epidemiologist and statistician, offered a variety of factors that he uses to determine whether there is causality in an epidemiologic evaluation. Since we know that just because there's a correlation, that doesn't necessarily indicate a causation. Other speakers may well also refer to the Bradford Hill criteria, and even though they are 60 years old, they are still being used. And I've given you as an example a study from 3 years ago looking at head trauma and CTE using the Bradford Hill criteria. I won't dwell on each criterion, but the strength of the association, the consistency, the specificity, the temporal relationship, a dose response curve, the plausibility, all those things were important to Bradford Hill, although it was not critical to satisfy everything to argue that there was indeed causation in the epidemiologic exposure. Not counting biosimilars, there are 5 main TNF inhibitors. One is a soluble receptor, that is etanercept. And it has an Fc portion of an immunoglobulin molecule to which the receptors are attached. It acts like a sponge. Of the 4 monoclonal antibodies, the first was infliximab. And infliximab is different because it's a chimeric antibody. It's partially mouse. Therefore, it is more foreign than the other 3 monoclonal antibodies. Adalimumab and golimumab are basically identical, fully humanized monoclonal antibodies. Certolizumab is different because it has a polyethylene glycol moiety, and that means that it is less likely to cross the placenta. So these chemical differences also equate to functional differences. Etanercept has the least risk of activating tuberculosis. But along with this kinder, gentler approach for etanercept, It shows a lack of efficacy in inflammatory bowel disease, sarcoidosis, and arguably uveitis, and the monoclonal antibodies are probably efficacious for each of those indications, if not definitely efficacious. Once upon a time, we used the nomenclature TNF-beta for lymphotoxin. That nomenclature has largely been abandoned, so it's not necessary to refer to TNF as TNF-alpha, but it's of note that the soluble receptor will bind lymphotoxin. As I mentioned, infliximab has the greatest likelihood of inducing neutralizing antibodies because it's more foreign than the other monoclonals. One of the advantages of infliximab is that it's given intravenously with a loading dose, and that loading dose goes along with a very rapid onset of action. I mentioned certolizumab not being likely to cross the placenta, and all the monoclonal antibodies will bind to TNF on the cell surface, whereas etanercept does not do this. In binding to TNF on the cell surface, if the antibody can activate complement, meaning it has an Fc receptor, it will presumably also induce cell lysis. So my group was arguably the first to do a large registry-based study on whether TNF inhibitors might induce uveitis. We made use of a registry that was maintained at the Oregon Health and Science University by the chief of ophthalmology at the time, Frederick Fraunfelder. That registry, when we looked in 2007, had 43 cases of uveitis attributable to etanercept, 14 with infliximab, and 2 with adalimumab. Now, those 3 TNF inhibitors were not in equal use, so we adjusted for how frequently each was being prescribed and concluded that etanercept was more likely to induce uveitis than the other 2 monoclonal antibodies. Oftentimes, these antibodies were prescribed for diseases like ankylosing spondylitis or psoriatic arthritis that were associated with uveitis. So if we restricted the analysis to diseases like rheumatoid arthritis that are not normally associated with uveitis, we still found that etanercept was more likely to induce uveitis. A better approach, arguably, because our registry had selective and not universal reporting of the toxicity, a better approach is a national registry that captures the entire population's use. A Swedish registry was reported in 2007, comparing adalimumab, etanercept, and infliximab. And as you can see, adalimumab had roughly a 50% chance of reducing the chance of uveitis, whereas etanercept doubles the chance of inducing uveitis. This holds even if you do certain adjustments for the Cox regression analysis. Finally, recently, a meta-analysis was published by a Chinese group, and it included 18 studies on TNF inhibitors inducing uveitis with over 11,000 patients. In this study, they concluded that adalimumab compared to etanercept has about a 70% less likelihood of being associated with uveitis, and etanercept was more risky than either golimumab or infliximab when it was compared to those 2 TNF inhibitors. So there is precedent for TNF inhibitors causing paradoxical reactions, as in sarcoidosis, psoriasis, and inflammatory bowel disease. And this includes either new onset of disease or worsening. No one has an excellent explanation for this, but think of the immune system as sort of a teeter-totter with checks and balances and needing very careful coordination to keep in balance. And you can imagine that the introduction of a TNF inhibitor could easily change that balance. So my conclusion is that evidence does strongly support the concept that etanercept can be a cause of uveitis and is less efficacious in the treatment of uveitis. Thank you again. I'm sorry I cannot join you in person.
Thank you to Dr. Rosenbaum. And we will now move on to case 2, which will be presented and discussed by Dr. James P. Dunn. Dr. Dunn, the floor is yours.
Is my audio working properly?
Yes.
All right. So I'm going to present a short case of ibrutinib-related uveitis. I have no disclosures to report. So ibrutinib is an orally available Bruton kinase, or BTK inhibitor, that's primarily used in chronic lymphocytic leukemia. The drug irreversibly binds to BTK. BTK is important in the signaling pathway for B cells. By irreversibly binding to the Bruton kinase, the Bruton tyrosine kinase, it causes decreased proliferation and increased apoptosis of malignant B cells. However, it also inhibits other kinases, including epidermal growth factor receptor, ITK, and MEK, and that can have an impact on its side effect profile. There are many systemic side effects that range from peripheral neuropathy and diarrhea, upper respiratory infections, urinary tract infections, bleeding, fatigue, cardiac problems, which fortunately are usually mild, and a variety of autoimmune skin, rheumatologic, and blood disorders. As we've seen, many of these drugs also have ocular side effects for the eyes. That includes red or dry eyes, subconjunctival hemorrhage, and more serious things such as branch retinal artery occlusion, cystoid macular edema, uveitis, optic neuropathy, which may not be specifically related to the BTK, but to other factors as well. So in our patient, this was a 75-year-old white male, excuse me, with CLL, who'd been treated with ibrutinib at the standard dose of 420 milligrams a day, going back to 2016. Also had monthly intravenous immunoglobulin infusions. He had a history of post-traumatic uveitis in August of 2021 that resolved with straightforward treatment. And then in September of 2021, developed uveitis with posterior synechiae that had been diagnosed elsewhere, for which he had been treated with and successfully responded to topical steroids. His workup for the uveitis, which included anterior and vitreous cells with a few snowballs, had been negative. He subsequently developed a cataract and underwent consecutive phacoemulsification with posterior lens implantations in April and May of 2023. And in November of 2023 and March of 2025 on his exams, he had no macular edema and his uveitis was well suppressed. He stopped the Imbruvica on July 12th, 2025. At that time, when I examined him, the vision was 20/70 in the right eye and 20/40 in the left eye, so it had dropped in both. He had normal intraocular pressure in both eyes. He had 2+ anterior chamber cells in the left eye and slightly less in the left eye. The posterior chamber lens was well centered. There was no evidence of an IOL-induced uveitis. And OCT imaging showed macular edema worse in the right eye with a central subfield thickness of 609 microns in the right eye and 408 microns in the left eye with an epiretinal membrane in both eyes. He was treated with prednisolone acetate 1% 4 times a day in both eyes, and Prolensa 0.07% once a day in both eyes. And then by this time, he had actually resumed the ibrutinib for his CLL. So just a little more than a week ago, his visual acuity had improved to 20/25, -1 in the right eye, 20/20 -2 in the left eye. Again, intraocular pressure was normal at 12 and 11 respectively. His OCT showed markedly improved macular edema with persistence of the epiretinal membrane more in the right than the left eye. His uveitis was suppressed and the posterior synechiae had resolved. This was his OCT image. The top photos on the right and left show the before and after treatment with the macular edema, which you can see responded very nicely with persistence of the epiretinal membrane. And on the lower two slides, left and right, pre and post treatment, you can see there was less macular edema initially, but again, by October 1st, had an excellent response with resolution of the macular edema and really just a trivial epiretinal membrane. So some key points about ibrutinib-associated adverse events. There's often a very delayed response. Typically, they occur 1 to 3 years after the onset of treatment. The most common adverse events include anterior and intermediate uveitis, optic disc edema, and cystoid macular edema. Patients with pre-existing uveitis appear to be at increased risk of ibrutinib-associated adverse events. Unfortunately, the associated adverse events usually respond to topical corticosteroids without the need for stopping the drug. So these are usually felt to be grade 1 or grade 2 adverse events. These are my references, and I'll just finish up there. I appreciate the opportunity to speak to the group.
Thank you so much, Dr. Don. Very interesting case. Now we will move on to case 3, which will be presented by Dr. Jennifer Hu and discussed by Dr. Lucia Sobrin.
Great, thank you so much. Everyone can see my slides here. Okay. So I'll be speaking on antibiotic-associated uveitis. So I will start us off with a case of maybe perhaps one of the most dramatic presentations. So this is a 67-year-old woman. She presented with 3 weeks of acute onset painless vision loss in both eyes. 28 days prior to when we saw her, she had had cataract surgery in the right eye. That was reported to be unremarkable. And she was very happy with her vision. She was 20/25. Therefore, they proceeded a week later to do cataract surgery for the left eye. Now, day 1 after cataract surgery for the left eye, the patient reported waking up with painless vision loss in both eyes. Her past medical history is noted for hyperlipidemia, high blood pressure, coronary disease, and vitiligo, and her ocular history was insignificant. The medications listed here are the drops that she was placed on post-operatively and initially when she was managed by the outside physicians. So we'll go over that a little bit, and she had no known allergies. On physical examination, her right eye was no light perception, and the left eye was light perception. She had fixed and non-reactive pupils in both eyes. Her ERMs were full, and her eye pressure was 38 in the right eye and 16 in the left eye. The anterior segment examination here, the subconjunctiva is related to procedures that were done in the management portion, so ignore that for now. But the cornea was noted to have significant defaults. There was trace cell and flare, no hypopyon, and posteriorly, it was a hazy view, but you can see that there are these areas of hemorrhage along the arcades here, both superiorly and inferiorly. And this was seen in both eyes, so I've only shown the right eye here. An ultrasound was performed given the poor view, and it was noted that the vitreous had some loose membranes and there was diffuse thickening of the ocular walls. Here we see a pretty impressive kind of choroidal thickening here. And then the UVM also showed some different membranous formations across the pupillary margin and as well from the iris ciliary body. Here again, we see some of that choroidal thickening. The pupillary membranes are difficult to appreciate in this slice of the UVM. So the differential diagnosis in this patient, she's post-operative after cataract surgery. So there's always a high suspicion for a bacterial or a fungal endophthalmitis. Though again, this is presenting the day after the second eye had had cataract surgery. Given the various hemorrhages in the retina, viral retinitis could be considered as well. The timing is certainly concerning for a toxic anterior segment syndrome, though she has a little bit more findings than just in the anterior segment. And given her medical history, one can also consider CRVOs or CRVO and CRAOs, and then finally medication toxicity. Reviewing the cataract surgery and the notes from the outside providers, the reported surgery was unremarkable. They did use lidocaine with epi as well as intracameral vancomycin at the end of the case, and her postoperative drops were as described here. They were the same procedure performed on both eyes, and no other cases at that same center had any noted other postoperative issues. So this patient was initially managed with a tap and inject. So she was covered for a bacterial endophthalmitis as well as a viral retinitis. She received vancomycin, ceftazidime, and ganciclovir. PCRs for viral etiologies were negative, and a vitreous culture actually from a vitrectomy showed no growth. Her serologies are as follows. She was seropositive for HSV, but negative for syphilis by RPR and FTA, and her other blood studies were otherwise normal or negative. And so in this patient, she's had really an overall negative workup for an exogenous endophthalmitis with very low suspicion for an autoimmune process. And given these hemorrhages and the severe presentation, the diagnosis was made of a hemorrhagic occlusive retinal vasculitis in the setting of intracameral vancomycin. She was treated with frequent topical prednisolone as well as oral prednisone. However, despite this, her vision was NLP in both eyes. She had severe hypotony. So this is just one of the most dramatic presentations that you can have of a drug-induced uveitis, and in this case, in the setting of an antibiotic. At this point, I'll turn it over to Dr. Sobrin, who'll talk to us a little bit more about HORV as well as other antibiotic-associated uveitis.
Thank you, Jen, for presenting that very severe case. She was that patient was actually part of the initial case report reporting this entity. Thank you to the organizers for the opportunity to present on antibiotic-associated uveitis. I have no financial disclosures. So we are going to talk primarily about HORV because it's such an important entity because it's so severe. And it is primarily associated with intraocular vancomycin, but we'll talk about one small variation on that theme. And then we'll talk about a few other generally less dramatic, but also very important antibiotics that can cause uveitis: oral moxifloxacin, rifabutin, and sulfonamide. So as Jen described our patient, she is a very classic, although severe, presentation of HORV. And the best review of this is in Ophthalmology from 2017. This was an international collection of cases of HORV, and it describes the cases in great detail. And so I point you to that paper as an excellent resource for learning about this condition. What we learned from that paper about the presentation of these patients is that most of the cases happened after uneventful cataract surgery. The patients either got intracameral vancomycin at the end of the case as prophylaxis for endophthalmitis, or they got vancomycin in their irrigation bottle. There was also one case of a patient who had cataract surgery, then developed inflammation without signs of occlusive vasculitis, got intravitreal vancomycin, and developed HORV in that eye. But primarily, we think about this in otherwise uneventful cataract surgery. These patients, as with the one presented, have delayed painless visual loss. They often have a totally normal exam on post-op day 1. And then when they do present at a median of about 8 days after their cataract surgery, the vision loss is quick and often quite profound because of the extensive vasculitis and ischemia. It can occur whether the patient is exposed to vancomycin in one eye only, or if they're getting it in both eyes or in a second eye sequentially. There are a couple of interesting observations. In some cases of the bilateral exposure, the HORV developed only in the second eye. And that led the authors to suggest that maybe there was sensitization in the first eye to the vancomycin from exposure in the first eye to vancomycin, and then that occurred. And then when the second eye was exposed, the immune system was primed to cause a reaction to the vancomycin. Also, in some of the bilateral cases of HORV, the reaction in the second eye was more severe and the onset was quicker. In some of these cases, when they look back, there was probably HORV already in the first eye that received vancomycin, but it was mild and just present as a few intraretinal hemorrhages in the periphery that were not really noted during the postoperative examinations. And then the second eye developed much more dramatic findings, which led the patient to come to the attention of the doctors as a HORV case. So these observations led to the proposed pathophysiology of HORV. The idea is that exposure sensitizes the patient after the first surgery and triggers the immune response after the second surgery. But as I mentioned before, it can also happen under unilateral exposure circumstances. In consultation with immunologists, the authors propose that this is a type 3 hypersensitivity reaction, similar to a leukoclastic vasculitis with antigen-antibody complexes depositing in the small vessels. They did do skin testing in 4 patients in this series. They did not show hypersensitivity to vancomycin, but skin testing really tests for type 1 and some types of type 4, and not really type 3 hypersensitivity reaction. So this is not definitive evidence one way or the other. But there is very strong evidence that vancomycin is the causative agent. Of course, all these patients, the thing they had in common was vancomycin exposure. But in addition, there's evidence for a dose response in these patients in this series. One of those instances is that cases that had vancomycin in the irrigation bottle were milder because, of course, the concentration of vancomycin that the eye saw was much less than when vancomycin was injected intracamerally at the end of the case. And then these patients, unfortunately, some of them actually received additional vancomycin in the postoperative period for the suspicion of bacterial endophthalmitis. And those patients who received additional vancomycin, like the patient we presented, actually had the worst outcomes with often and no light perception vision at the end. And so I think this is the proposed mechanism. We don't have 100% certainty, but I think there's very strong evidence that vancomycin is the causative agent. So we'll talk a little bit about the clinical features here. The vision can range. There are mild cases and with vision presenting as good as 20/20, but usually they're 2200 or worse when they present. The anterior chamber inflammation can be mild to moderate. There's usually no hypopyon. Our patient had quite a bit of anterior segment findings. However, she had also been through vitrectomy and multiple procedures before she came to see us beyond the cataract surgery. And so that might have influenced her severe presentation. The vitreous inflammation is typically mild. And then, of course, the most important thing to observe is this hemorrhagic occlusive retinal vasculitis. And here you see a fluorescein angiogram from that case series, which is so dramatic with really significant peripheral non-perfusion and intraretinal hemorrhages throughout the periphery. As in our patient, all these patients typically had good workups for other causes of uveitis, and they were negative. And the other very significant and important thing to look out for is that these patients, because of the extensive ischemia, rapidly progress to neovascular glaucoma and therefore need to be very carefully monitored for that complication. The treatment for this condition is, first of all, to control the inflammation. We typically do this through topical prednisolone or systemic prednisone. In the 36 patient case series, there were a couple of patients who got intravitreal steroids, and anecdotally, those patients did better. So that's something to consider to control the inflammation quickly. Then we have to deal with the ischemia and prevent development of the neovascular glaucoma. And for that, anti-VEGF injections followed by panretinal photocoagulation are the treatments that need to be implemented. And of course, avoiding additional vancomycin exposure is very important. And it's important to recognize that this is not endophthalmitis, because vancomycin is a very commonly used intravitreal treatment for bacterial endophthalmitis, and we don't want to make the disease any worse. So what has come since this entity has been described in 2017 in that large case series? What we've seen is a shift in how cataract surgeons use vancomycin. So back in 2014, when they did the member survey for the ASCRS, 36% of surgeons back then were using intracameral antibiotics at the end of the case, and 22% were using vancomycin. So a significant proportion of surgeons were using vancomycin. In 2017, this case series came out and the FDA issued an alert. And since then, when they were surveyed again in 2021, although there was still a significant growing number of surgeons who were using intracameral antibiotics, vancomycin use was decreased significantly. And the recommendations from the 2017 paper do note that this is an extremely rare occurrence with intracameral vancomycin, but it is still there and present. And I think cataract surgeons have become aware of this and choose to use other intracameral antibiotics instead. Is there a risk of HORV with other antibiotics? So the only other antibiotic where HORV has been reported is moxifloxacin, intracameral moxifloxacin. And this is based on a case series of 2 patients with HORV following that. One patient had a very good outcome. The second case had a less good outcome with a vision acuity of 2300. You can see in this clinical photograph that they look very much like the vancomycin-associated HORV patients. We really haven't seen many other reports, so it's unclear, but possible that this reaction can also happen with other intracameral antibiotics. Now, although this is only rarely shown to, uveitis is only rarely shown with intracameral moxifloxacin, oral moxifloxacin is a different entity. And so now we're going to be shifting to other kinds of oral antibiotics that can cause uveitis. And moxifloxacin among them is one that causes a very distinct appearance. So these patients that develop moxifloxacin-associated uveitis often are taking oral fluoroquinolones, most commonly moxifloxacin, for a pneumonia or a UTI. And they develop this very dramatic bilateral acute iris transillumination defect, or BAIT. Now, there's some debate in the literature whether some of the cases of BAIT are due to moxifloxacin versus just a reaction to the underlying virus that's causing, or bacteria that's causing, the infection for which they're being treated. Because there are some patients who develop BAIT without being exposed to moxifloxacin. But even in the larger case series, the majority of patients who develop BAIT do have exposure to moxifloxacin. So we will concentrate on oral moxifloxacin as the likely cause in most cases. So they present with an acute anterior uveitis, so very different from HORV. And then the transillumination defects are very dramatic, as you can see in this representative case from a case report in 2020. Their pupils often don't respond well to light. Typically, it starts 7 to 10 days after they are using the oral fluoroquinolone, and it's suspected that the oral fluoroquinolone has a direct toxic effect to the pigmented iris tissue. And we usually manage this with topical steroids. Unfortunately, the transillumination defects persist, and patients are often very bothered with light sensitivity after this. What is the evidence in the literature that moxifloxacin is the culprit and not something else? Because as you all know, this is a very commonly prescribed class of antibiotics. So there was a large case control study with 26,000 patients that looked at men over approximately 15-year period, and they looked at the risk of uveitis with different fluoroquinolones. And so what you can see here highlighted in red is that moxifloxacin had a very high rate of cause of being associated with new onset uveitis cases. Ciprofloxacin also was associated, but at a much less, much reduced relative ratio, and then levofloxacin was not significantly associated at all. So this evidence is that this provides additional evidence that moxifloxacin is the culprit. It's not just the underlying viral illness, because if not, we would also, in theory, see it with levofloxacin. And this also suggests that maybe some patients with ciprofloxacin might develop this, but it's most significantly reported in the literature in association with oral moxifloxacin. Rifabutin-associated uveitis also has a distinctive appearance. It's one of those causes of hypopion uveitis that we think about in that differential. They don't always have to have a hypopion, and in some rare cases, they're not even anterior uveitis. They can present with intermediate and posterior uveitis. Here, the onset is weeks to months after the initiation of therapy, and many times they are on a concurrent therapy that inhibits rifabutin metabolism, and so potentiation of rifabutin contributes to the development of the uveitis. Here, topical steroids are very effective, and many times rifabutin needs to be stopped to really resolve it completely. And I should mention that often in the oral moxifloxacin cases, patients are almost at the end of their moxifloxacin course by the time they come to presentation, but we do, of course, in the future tell patients to avoid moxifloxacin. The last antibiotic that has been reported consistently to induce uveitis is sulfonamide, and this is primarily sulfamethoxazole trimethoprim. And the presentation here is typically a bilateral non-granulomatous anterior uveitis. The best series about this kind of uveitis was back from 1991. The onset is within a few weeks by this series, and these patients resolve well with good outcomes with topical steroids. And of course, we do tell them to avoid sulfonamides in the future. It's important in these patients to look for other sulfonamide-associated side effects in this series. The uveitis was often in conjunction with something else, such as Stevens-Johnson syndrome, elevated LFTs, or erythema multiforme. So in conclusion, really important to take a thorough history in patients with uveitis, particularly a medication history. Some forms of antibiotic-associated uveitis can be visually devastating or very visually debilitating. And so it's important to identify them quickly and prevent further exposure to the antibiotic. Intervention often involves stopping the offending agent or preventing future exposure. But even with this, the effects can be irreversible for some of these agents. And so very important to identify and distinguish from other forms of uveitis. Thank you to the organizers for this ability to share this information with you.
Thank you so much, Jen, for this for presenting this challenging case, and thank you, Lucia, for this beautiful presentation and discussion. Now, if we have questions, and also thank you very much to all our speakers and discussants for such an insightful session. Today's presentations highlighted the complexity of drug-induced uveitis, reminding us of the importance of detailed clinical assessment, careful review of therapeutic history, and the use of targeted diagnostic tools to distinguish these cases from infectious or autoimmune causes.
I think there is a question for Dr. Dunn, which is unanswered by Stefan. Is Dr. Dunn there?
Yes, I'm here.
Yeah. The question is your case purely ibrutinib-induced uveitis, or was it an exacerbation of pre-existing uveitis?
All the workup was negative, so our assumption was that this was truly ibrutinib related.
Thank you. So over to you, Alejandra, for further.
Okay.
Can I just
No,
make
we
comment?
have time. If not,
Yeah.
yes, we have a little more time.
I'm sorry. I just wanted to make a comment too. Some other medications you may encounter to look out for that have been known to cause uveitis include the bisphosphonates, with a more rapid onset of the uveitis if it's given IV, and then it resolves once the bisphosphonate it loses its effectivity, whether it's several months or even a year long, and you can maintain them on topical corticosteroids. And also vaccines can cause a drug-induced uveitis, with the most commonly encountered being the influenza vaccine.
There is also a question on to how long can uveitis last after infusion of alendronic acid? Anyone from the panel?
It
The
should
cases
last.
I've seen are, sorry,
Oh,
Yes,
it's okay.
Lucia,
Go ahead. Go ahead.
no, I'll just say the cases I've seen are typically pretty self-limited and respond quickly to steroid therapy when they're topical steroid therapy when they're anterior uveitis. So I haven't seen them persist, but I've only seen a few.
Yeah, I agree. I think once the medication loses effect, if you can just maintain them on corticosteroids, then the uveitis will self-resolve.
I think it's
And
worth
that I-
noting that a lot of patients suffer from reading the literature and then generalizing dramatically to their own individual case, or their physicians generalize. So we have a patient who has a history of uveitis and they've got significant osteoporosis in this particular case. And the patient says, well, I can't take any of the bisphosphonates because I have a history of uveitis, or I will get uveitis, even if they've never had uveitis. And of course, the morbidity and even mortality associated with hip fractures in older patients is dramatic. And we have to emphasize to the patients, yes, these are potential side effects, but they're rare. And as with any drug that we use, it's important to understand the relative risks and benefits. And the risks of mild uveitis that responds well to topical steroids versus the risks of a hip fracture are not even remotely comparable.
Lucia, there is a question from John Kempen for you that if you have ever seen HORV following Venco for endophthalmitis, and should we avoid its use in this context?
Yeah, that's a great question. I sort of alluded to the fact that in that case series of 36 patients, there was one patient who had cataract surgery. Then they didn't have intraretinal hemorrhages or anything suggestive of HORV, but then had inflammation postoperatively, then got intravitreal vancomycin, and then developed the appearance of HORV. And so, yes, it has been reported. However, as you know, vancomycin is one of the best antibiotics to use because of its broad coverage in cases of bacterial endophthalmitis. This has raised the question whether we've been using intravitreal vancomycin for years for endophthalmitis, whether HORV has happened in the past, and it's just that bacterial endophthalmitis is so severe that we confound what could be a HORV type reaction just with the disease of bacterial endophthalmitis itself. And that's probably true, but as I mentioned, intracameral vancomycin is used very commonly, and HORV is very, very rare. And vancomycin is a very effective antibiotic. So as far as I am aware, no retinal specialists have deviated from using intravitreal vancomycin in their use in treating bacterial endophthalmitis, and I don't think we need to do that. But it is true that maybe once in a long while, one of those patients with bacterial endophthalmitis getting intravitreal vancomycin may develop HORV, and we may not be able to detect it well because of the severity of the bacterial endophthalmitis.
I totally agree with you. Like, I'm a retina surgeon as well. We had issues with amikacin, like when we used to give long time ago. But Venco is a safe drug and an effective one. So, John, probably not yet to change. And one last question for Dr. Dunn, that in your case, if the patient develops chronic kind of a uveitis, would you give immunosuppression?
I mean, it's a tough call, and as Megan pointed out in her excellent overview at the start of all this, you have to weigh those risks and benefits. And if the patient is responding well, if their CLL or other malignancy is responding well to the treatment, and the oncologist says, I don't really have other options at this point, you have to decide how risky the use of immunosuppressive therapy is. Can you manage it without jeopardizing the benefit of the ibrutinib for the CLL? You know, can you treat locally with steroid injections or steroid drops without going to immunosuppressive therapy? So I think you can do that, but it obviously requires, as Megan had pointed out, careful interaction between the oncology team and the ophthalmologist about what is the best overall approach for the patient.
Well, if there are no more questions or
I
comments,
have more question.
yeah,
And could topical medications such as hypotensive agents derived from sulfonamides also induce uveitis? Do you have any experience? Because among the ocular hypotensive agents, those derived from sulfonamides include carbonic anhydrase inhibitors like or topical dorzolamide, brinzolamide, acetazolamide also. So because these medications contain a sulfonamide group in their chemical structure.
I think there are rare case reports of that. Actually, the topical antihypertensive that's been most associated with uveitis in my experience is brimonidine. That one often can cause a granulomatous anterior uveitis, but I think it has been rarely reported in these other drugs that you mentioned that have a sulfonamide group.
yeah, choroidal detachment following Diamox therapy, sudden hypotony, that has been reported with topiramide and carbonic anhydrase inhibitor. But that's not truly uveitis, it's just kind of an acute hypotony.
Okay.
I think one of the more fascinating aspects of moxifloxacin-induced uveitis is that, to the best of my knowledge, that's not been reported in topical moxifloxacin therapy. Janet Davis and her colleagues at Bascom Palmer wrote a paper on this a number of years ago. It suggested that the reason why patients with oral moxifloxacin-induced BADI had to do with relative concentrations of the drug in the anterior chamber between topical and systemic therapy. I don't know if that's been proven or not, but obviously we use the topical fluoroquinolones all the time, and we don't get that same risk.
I had one patient, Dr. Dan, where they used it after LASIK surgery, and he developed body, and the moment we stopped fluoroquinolone, everything just disappeared. But I don't know whether it was to do something with more penetration post LASIK. I have no clue.
Yeah,
And
it's an interesting thought.
an Argentinian group Dr. Ariel Schlein's group presented a poster in the IOIS meeting in Brazil with 3 patients developing uveitis with topical moxifloxacin.
I wonder if the the anterior chamber acquired immune deviation could explain cases where systemic exposure seems to cause the side effect, but topical or intracameral exposure doesn't.
Anyone?
I was going to mention too that medipranolol also has been associated with uveitis rarely, and I think people use timolol instead now.
Well, that brings us to the end of this year of webinars, and thank you everyone for joining us. 2 announcements which I had to make. One, thanks to John, Megan, Alejandra, they are writing a book on whatever has been said in the webinars, and the book will be released during IUSG, and please save the date for ISO 2026, which will be held in Tübingen, and we do have a basic course along with it. So it's very important you block your slot if you are interested in the basic course, because we do have a limited capacity. Thank you everyone, and we will see you in January onwards, where we are planning the case presentations by different group of institutes. And John, would you like to conclude about January plan, or Alejandra?
Sure. So we have been sort of approaching this thematically for some time, with the idea that we could expand the presentations into the chapters of a sort of case-based learning textbook, which Alejandra for the first half and now Megan has taken the lead in writing based on this, and Rima also has been involved. And now we're kind of getting to the end of that. And so, but there's a lot of interest in this grand rounds and a lot of need to know about uveitis. So we've been expecting to continue doing it, but not write books from it. And so our idea is to ask large centers in turn to each present grand rounds once a month, probably again, like 10 months a year. So we're not completely finished with organizing that, but likely that will be organized for January, and we will sort of update the people that are sort of subscribed to confirm the announcement when it's ready. So keep watching and stay engaged, and there should be a lot of more good opportunities to learn about uveitis from interesting cases, which is, I don't know, in our grand rounds, our Harvard grand rounds, I think the uveitis must be at least 40% of all the cases, because it's so interesting, not that other areas of ophthalmology are not interesting, but uveitis is especially fascinating. So
enjoy your holidays. Happy New Year, everybody. And we will see you in January. And Alejandra, with Moorfields beginning the grand rounds?
Yes, we'll start with Murphy's grand rounds, yes.
Thank you, everyone. Thank you, education team. Thank you, our speakers, Dr. Dunn, especially for joining us. Thank you, everyone.
Thank you,
Thank
Vishali,
you.
and thank you
Bye,
to all
everyone.
of you. Thank you.
This is fun.
Bye.